Good evening, everyone. It is 7:05, so we are going to get started. For all of those listening and viewing, my name is Victor. I'm one of the incoming residents at the Miami Neurosurgery program, and today with my co-residents Damien and Sumed, we're very excited to share with you just a new initiative we have during these unique times called the Resident Hour, and we're aiming to do this every last Tuesday of the month and just talk things about, all things neurosurgery from our perspective, as trainees here at Miami. And so this will be a regular thing. Our schedule is actually on the link in the bottom right corner for all those that are interested in seeing what's in store and to subscribe to regular reminders. And just quickly before we go on, for all of those people that are interested, given that these are unique times, our program is performing virtual sub-internships this year in line with the guidelines of the SNS. And just while we wait for the last couple people to trickle in, for all those that are interested, here is the promotional video, which I think kind of summarizes and puts us in a good mood for us residents to provide the next hour of didactic talk on meta-analysis. And so we've even just then got some questions. How do you sign up for that? Here is actually the link. If you come up to the neurosurgery.med.miami.edu website, it's the first button here to sign up. And it's for everyone, anyone that's interested, any stage, any place, any location. So just keep that in mind. And all those people you saw in that video were residents. And, the goal is to have us all involved at some point in these resident hours as we progress through the year. But without further ado, the topic for today, the one that we want to present, is something that I was very close to, my heart, and also my co-presenters as well, is how to utilize and synthesize systematic reviews and meta-analyses in neurosurgery. It's a hot topic, and together with Damien and Sumed, we're looking forward to sharing with you our perspective of things, both as a learner of these things, and as also people that have published these as well. And we welcome any questions during this talk. And effectively, what the main objective of this talk really is to make us more sophisticated. There's a lot of this stuff out there, and we need to be better at reading and writing these particular types of studies. And so this is what we're here for. Just quickly, we'll start with a very brief introduction, and then Sumed's going to talk about how to get started with these talks. Damien will talk about executing them, and then I'll finish up with our fine-tuning. At that point, obviously, we'd love some questions and have an open discussion. One hot topic is always about the value of these types of studies in neurosurgery, and we can provide our own opinions on that as well. So that is at the end. And so just quickly, for those that aren't particularly aware, that if you consider all literature reviews to be this big sort of portion of the literature, within that exist systematic reviews. And what separates a systematic review from a literature review is that the way it's conducted is systematic, it's organized, and it's designed to truly encompass every possible study pertinent to the subject. Whereas a literature review is slightly broader in the sense that it doesn't necessarily have to capture every single study. Whereas a systematic has a specific search strategy, as we'll talk about soon, and one that then summarizes the data. Within these systematic reviews, you can have what are called meta-analyses. And what that does is it takes the data from the studies a systematic review finds and pulls them, summarizes them, and often perform statistical analyses on them to generate pooled numbers, pooled quantities that can be used. Of note, you might be interested to know that there is this little section of meta-analyses that does not overlap with systematic reviews, but just literature reviews, because meta-analyses themselves is just the statistical analysis of metadata. They don't necessarily have to be systematically identified. So there is a small portion, not a very large portion of literature, but one nonetheless. And these studies represent what is known as the highest quality of evidence. On the left here, you can see that systematic reviews are at the top of the evidence food chain pyramid. But more interestingly, if you take that and you look at the exact levels of evidence, you can see that meta-analyses and by consequence systematic reviews lie at level 1 and level 2. I like this diagram on the right because it shows that whilst meta-analyses can be considered the highest level of evidence, they are technically of the homogeneous randomized control trials rather than the other studies, which are on par with other studies. But nonetheless, systematic reviews and meta-analyses in terms of levels of evidence remain quite high up. Why this is quite interesting, especially within neurosurgery, is that within recent years, within the last decade, there's been an exponential growth of these studies. You can see just a search of PubMed yields a very large growth in these studies. If you combine meta-analyses and neurosurgery, you see something similar, as well as meta-analyses and spine. So ultimately, these studies are booming. And what we hope to do in this talk is summarize our experience with them, how we start with them, how we execute them, fine-tune them, and perhaps question, what value they have and how you can go about doing them yourselves. So without further ado, Sumit is going to take us through the first part of getting started.
Hello, everyone. Thanks, Victor, for introducing the topic very well. So, the part of the reason why we wanted to have this talk in general is because while Victor had mentioned that the systematic review meta-analysis kind of sits at this pinnacle of the evidence food chain of sorts, this is oftentimes some of the first types of research that medical students, junior residents are really thrown into. And so part of the reason why we wanted to have this topic was for particularly those who may not be as facile with kind of how the process works, this would be a great way to show. So like any data-driven paper, systematic reviews and meta-analyses, you need to have a good idea. And so where do these ideas come from? Well, when you're a medical student and you're kind of, new to the literature and new to the field and such, a lot of these ideas are going to come from those above you. So these are going to be those residents, they're going to be those attendings, and a lot of the questions that are posed really come from clinical practice. An interesting case that had an interesting outcome, and then you're attending, a resident above you is interested in seeing, well, what else has been done? Is this something that's been tackled? In terms of the actual literature readings itself, you also have ideas coming from there. All of us do spend some time perusing through the literature, and it always comes to, there's always a line that exists in these papers where we're not sure why this works, or we're not sure how this works. So when you read the literature itself, this allows you to kind of see what gaps of knowledge exist, and maybe how you can implement this kind of systematic review and meta-analysis into your own kind of practice. And finally, your personal interests or your mentor's personal interests. And this is kind of where a lot of, for example, for me, how I kind of got my first start. And so we had mentioned, we show that where our ideas have come from. Well, my first meta-analysis systematic review actually came from a pharmacologist who had an interest in pediatric brain tumors. And so that's kind of how she got me interested in looking at this particular, at that particular topic, how pediatric brain tumor survivors, how they do psychiatrically down the line. A lot of data exists in these kind of pooled fashions, yet together was the idea behind the meta-analysis. And so I know Victor, Damien, if you guys kind of want to chime in as to what your guys' first ideas were and such.
Yeah, I can just quickly say my first idea came from when I was a student on a sub-I, and the attending at the time said, why don't you look at this? And it was simple as that. The question was, why don't you look at this particular comparison? Go and just see what's out there. And from there, it just kind of went from there. But that's where I got my first idea from.
Yeah, very similar for me. I was a medical student working with my mentor here, Dr. Wang. I'm actually going to talk about this example a little bit when we get to my slides, but it was a series of systematic reviews, and since then has kind of spawned a number of other papers and clinical questions and things like that. So it can really be a great starting point for you if you're looking to get into a particular topic.
Awesome. Thanks, guys. Yeah, so then this then brings us to the topic of, so now you have the idea. How do you kind of start to whittle it down into something that is actionable? And so there's this beautiful acronym, the PCOS, however you want to pronounce it. But ultimately, this is kind of a way to frame your idea into an ultimate question. So population, the types of studies you're going to include. This is what kind of encapsulates this idea. So the population, for example, for this paper that I had written earlier would have been pediatric brain tumor survivors. Okay, well, within that group, what are you doing? So what is the intervention these pediatric brain tumor survivors had gone through? Well, surgery, chemotherapy, radiation. I'm just using this as an example. So you would use this kind of process for your particular idea to frame that question. The comparison for this particular topic was non-pediatric brain tumor patients, and then the outcomes were psychiatric comorbidities. The study types we included were basically any clinical paper, case reports that talked about the psychiatric effects of brain tumor therapies when people were children. And so this is kind of the PCOS is a kind of a way to, in the back of your mind, you have your idea, how do you frame it into an actionable question? So keep that in mind. And so if you want to then move to the next slide, Victor. So then now you have your question. So now begins the data collection portion. And there's a lot of different metrics you can use, a lot of different guidelines that exist because, as Victor had pointed out earlier, meta-analyses, systematic reviews are becoming more and more prevalent in the literature, yet with all of this increase in PubMed to determine its quality as a meta-analysis. And so the one that we showed here, and many journals will actually require that you use this checklist, the preferred reporting items for systematic reviews and meta-analyses, the PRISMA checklist, in order to actually publish your systematic review. And this goes down to basically through what the title should include, what the abstract should include, how you should introduce the different topics. So this is kind of the way that when you're a medical student, when you're kind of getting new into this types of research, using these checklists not only are very beneficial for you to kind of help guide what you do, but they're actually becoming required, particularly for publication purposes. So keep the PRISMA checklist in mind. And we're going to refer to this a little bit later, Damien is going to, but again, this is something that when you're collecting your data, you want to keep in mind. So the actual collecting of the data is generally very topic specific. So generally what you're going to do is you're going to look through the literature for different papers that have of different study types, and you're going to basically read through them and parse through and collect data from each of these papers. And one of the things, looking at blood blister aneurysms of the internal carotid artery. And basically the only premise behind why I wanted to show you this was to show kind of what this is going to, your data collection is going to look like. You have all these metrics that you're trying to observe, demographic metrics, outcomes metrics, follow-up metrics. And so if you look at the above, author, study type, patients, their general ages, where the aneurysms were located. These are the kind of factors that are going to go into your paper. So you need to look at these types of metrics from the papers you're looking at itself. And then one of the things I would always recommend for anyone doing these is if you have all these data points and some of them may seem redundant, some of them may seem unnecessary, I would still gather them. There's nothing worse than basically going back and finding out that, well, we needed this data point, we needed follow-up duration, but we didn't have that. We didn't look at that in the beginning. So now we're going to have to go through each paper individually just to find that data point. It's always okay to include less in your paper as you decide to see fit, but it's not okay to have to go back and parse through 15, 20, possibly like dozens of papers that just for one little data point. So then now you have your data. How do you analyze it? And this is kind of a debate whether or not different softwares are useful, whether or not you should use or learn how to do statistical analysis yourself. I came to the conclusion early on that a lot of my medical education, a lot of the time that was spent in learning statistical analysis while it was going to be beneficial later on, there are so many ways that you can actually do meta-analysis on your papers, on your own studies, without actually needing to know how to code, without having to know how to make forest plots by hand or something, like any of that. What I would recommend you do is, once you have this data, what I would really recommend is going online and simply typing in meta-analysis analysis software. There are hundreds of thousands of results, millions in fact, sorry, that exist that allow you and show you how to do your meta-analysis. And I'm not going to name any specific programs, but for example, if you were to just type this into Google, the first hit that comes is top 15 free meta-analysis software, So there's no real need for you to be a stats expert in order to do meta-analysis. Granted, having an understanding of stats would be beneficial, but for the purposes of an actual writing, how to get started with meta-analyses, learn how to do these things as you go, but you don't have to sit there and reinvent the wheel. You don't have to relearn statistics when these programs exist. So finally, actually writing the paper, that's the name of the game, right? So when you write your manuscript, what would be very recommendable is going to the actual journals that you are going to be submitting in and looking at what their requirements are for meta-analyses and reviews. So a lot of journals have, for example, table figure limits, word count limits, heading requirements. These are the kind of things that you should be aware of before you actually even start writing, so that you don't have to go back and modify how many words are in your manuscript. This is going to follow the same type of, generally speaking, the same type of format as other clinical papers: introduction, methods, results, discussion. But it's very important. This is the reason I put the limitations in red, is because there are limitations that exist to meta-analyses. And these are important because you're not synthesizing your own data. You're synthesizing other people's data, multiple different types of data collecting mechanisms that each of these authors use. You're putting them together. There are limitations that exist. And finally, one of the things that I want to kind of show at this point as well is that meta-analyses, systematic reviews actually do, in the long run, I truly believe, effectuate change in clinical practice. This is a paper that I was very fortunate to be in part of earlier on in my medical school career, which was just looking at cardiology data for neurointervention, for endovascular neurosurgery. Cardiologists use the radial artery for a lot of their interventions, and I won't go into the specifics of that, but the idea was, well, let's just review the literature of what cardiology did. And what we found, we came to the conclusion of, Dr. Snelling, one of my mentors when I was in medical school, and Dr. Peterson, they basically kind of and said, well, hey, let's continue approaching this topic and look at the kind of things that can come out of it. Truly game-changing, patient quality types of metrics that can come out of these kind of projects. So these are all the papers that we had looked at.
All right. Well, thank you, Sumedh. So now I'm going to piggyback off of what Sumedh talked about and discuss some of the finer details of how to execute these systematic reviews and meta-analyses. And I'm going to really focus on the literature search aspect of it, because especially as a medical student, that's more than likely what your role will be on that particular project, and it can really be your time to shine if you can hand in a very well done, organized literature review to the resident or the faculty member. And that can be a real, key way to impress them just by, following a simple set of steps. But before I get into that, I want to touch on, a couple of the issues of systematic reviews and meta-analyses today, and kind of how they relate to what Sumedh was talking about regarding generating ideas. So not all topics can have systematic reviews and meta-analyses performed, and not all topics are, with those analyses are actually correctly performed. And so I'm going to touch on the PRISMA guidelines, like Sumedh alluded to earlier today, as a simple checklist and things to follow so you can ensure that you are correctly performing your review and that it makes a valuable contribution. And then regarding clinical reasoning, not all topics need to be performed, via systematic review or meta-analyses. You obviously want to take a look at the literature, and if there have been, 1-2 meta-analyses performed on the topic you're interested in, it's probably not the best use of your time to publish a third, within the next year. So things to look out for, and really what systematic reviews, meta-analyses can do are aggregate cohorts from multiple different studies, multiple different papers to build a larger sample size that you can, study and look for different effects. And to that point, they can then inform practice. So an example here is risk of cardiovascular events in rofecoxib cumulative meta-analysis. And so they looked at all the cardiovascular events gathered from all of these different studies that had been published on it, and ultimately, they found it was too risky and they took the drug off the market. And so that's something that has a valuable and clinical impact just based on the meta-analyses that was performed well. It can also identify gaps in knowledge and evaluate the quality of current literature, which ties into the next slide here, where it cannot improve that quality of current literature, the old adage, garbage in, garbage out. So these are really just a summary of the current literature that exists out there. And so it's not creating any new conclusions from these studies. It's just summarizing what the current conclusions are currently out there. And so therefore they're different to clinical studies, an apple's not an orange. So now kind of into the meat of what I wanted to talk about, which is how to really structure your literature search and how to execute a properly done systematic review. So as Sumedh talked about the PRISMA guidelines, he showed the checklist there, but I think arguably more important as a resource for you when you go about your literature search is the flow chart that's on the right side of the screen. And oftentimes it's included in as a figure in the manuscript, and I think really should be, because then it allows the readers to understand that your review process was rigorous, you followed the PRISMA guidelines, and therefore it was an effective and valuable systematic review. So certainly check out the website, the PRISMA statement. It has everything you really need to get started. And it's really imperative to stay organized during this literature search process. That's why it's called a systematic review. You systematically go through and search the literature so that you can get the most comprehensive and exhausting search you can. So I'm going to talk about an example that I did that I mentioned briefly earlier. And it was working on the ERAS Society guidelines for lumbar fusion. So I originally started as a medical student working on this, with my mentor down here, Dr. Wang. And so I want to show you the process for, how this came about. And this isn't a talk about ERAS, so I'll let you look that up on your own. But briefly, what ERAS guidelines are they're structured essentially as individual systematic reviews for about 20 different perioperative interventions, ranging from preoperative nutrition to postoperative nausea vomiting treatment. And that's all tailored specifically to, in this case, lumbar fusion. So the red box on the right, I kind of highlighted, maybe a little hard to read, but basically what it says is that it's the statement from our methodology section in this textbook chapter that says the current review was developed based on specific search criteria to allow a comprehensive review of the literature according to PRISMA guidelines. So that's really a key statement in any methodology section. If you look in literature reviews, meta-analyses in the literature, you will oftentimes and probably should see that statement to ensure that they went through a rigorous systematic review process. And so if you could go back a second, Victor. So overall, I was, when I first, talked to Dr. Wang about the project, he was like, okay, well, you're going to be responsible for 15 of these 20 topics. So now I have 15 systematic reviews on my hand to do, and I'm not really that familiar with them as a medical student. So it was definitely a challenge, and I knew it was going to be, critical that organization, was going to be key. And so thankfully, the PRISMA guidelines lay the process out very nicely. And so for the sake of time, on the next slide, I'm just going to show you for my search process just for one of these, 15 topics. But once I got one down, I was able to just repeat that process for the other 14 topics, and it actually ultimately ended up going fairly smoothly. So on the slide here, on the left side is the search strategy, which is critical to get even prior to the whole search process. And so in the green box, you can see all of the different search terms that we used. And these were all determined ahead of time. And really what I just had to do was enter them into PubMed, CINAHL, there's Ovid, there's a bunch of different online databases that you want to look through. But the key is to use phrases like the and in all capitals or to make sure that you link all these phrases together and so you don't miss anything. And another point that I didn't know and found out during this whole process was the asterisks that you can see, like spin surgery. The asterisk denotes a combination of the word either spine or spinal. So instead of typing, a million different codes, you can just use that asterisk and it'll kind of tag, and include all of the additional words, and it'll save you a little bit of time and a little bit of hassle. And then below that in the red box, as you can see, are the number of hits. So, or AKA number of searches we found. And you can see it's quite a lot there. 430 if you include all three of those, which is ultimately what we were looking for. And then after we remove duplicates, based on all the different databases you look through, then there's 363 papers, titles, abstracts of papers that I had to go through just within PubMed to determine which ones are relevant. Fortunately, a lot of those, based on just the title or the abstract, you can eliminate. And so that's kind of how I was able to whittle it down relatively quickly to just 18 topics. And how you whittle those down is based on the inclusion and exclusion criteria you see on the right that you determine ahead of time. And so here we were only looking at the postoperative nausea prophylaxis, antiemetic therapies, and they also had to meet all these other inclusion criteria. Lumbar fusion, they had to be adult. The outcomes had to be either complications or the outcomes themselves, such as length of stay. And so those are really key things to have even before you start your search strategy, which is daunting in and of itself. And that's where you sit down with your team as a medical student, or even junior resident. You may not be the one coming up with all of this, but it's certainly something you need to understand before you go and do your search. So next slide then, Victor. And so ultimately, after I did the search, this is the flow chart that I had, and you can see it filled in there. Records identified 430, duplicates removed, records screened, shows how many were excluded, and then full text articles assessed. So that was the 18. And then that's kind of when I passed the torch on to the rest of our team, and they were the ones that went ahead and read the full texts and ultimately determined that 10 of them would be included in the qualitative synthesis, aka writing about them in our guidelines. But the important piece here as well is that the rightmost side, you see the full text articles excluded with reasons. And so of those 8 articles that we excluded, you want to list why you were excluding them based on the full text review. So for this example, 2 were review articles, and that was part of our exclusion criteria. 4 were talking about different outcome measures that we weren't interested in. 2 were on deformity, which was unrelated to what we were specifically looking at. And so that's something you want to note as well. And if you see that in the Prisma figure that they include in the paper, then they really took their time. They went through, and it was a truly rigorous process. And then as you can see here, the final box at the very bottom that's left blank because we didn't do a meta-analysis for this particular guidelines. But if you were to then ultimately analyze those papers that you included in the qualitative part, then you can quantitatively analyze that, and they have a little section there in the chart to add the number of those papers as well. And so I showed you how I like to organize my literature search, but regardless, you want to do what works best for you, and it should ultimately be easily translatable into that flow chart that I showed. And again, I had to repeat this process 14 times. So I made a separate folder, a separate document with the search tables, PDFs of the articles, the flow charts. They were all kind of separated individually in different folders, so I was able to keep track of them. And so that's something, that I highly recommend, you do, especially when you're first starting out, just to keep everything organized. And then ultimately becomes fairly routine. And so then the last piece that I want to focus on, because it does relate to the guidelines that I was talking about, is what's called the grade assessment. And you will likely come across this while reviewing systematic reviews, meta-analyses, and certainly for consensus guidelines like ERAS. And it's really a simple but effective way to summarize the strength of the evidence that you've gathered during your review, and then posit a strength of recommendation for those studied interventions. So as you can see here, this is just kind of like an excerpt taken, and intraoperatively, you have a couple different topics that we looked at, and what our recommendation was. Intravenous antibiotic prophylaxis prior to skin incision is recommended. But the level of evidence was, medium, meaning that there weren't a lot of randomized controlled trials providing the highest level of evidence that gave us, absolute certainty that, oh, these are, absolutely recommended. But we can give an average strength recommendation that says most of the studies, the observational studies that we had showed that they were beneficial, so you should do this. Versus the blood loss protocol, use of tranexamic acid, they're not recommended. So there's not a lot of level of evidence, and the strength is kind of weak. So we, subjective to some degree, but you want to look at the level of evidence with randomized controlled trials obviously being the highest level of evidence and observational studies being the lowest, because it's based on the inherent bias, related to each of those methodologies. So that's also something. Prisma and grade are the two, I think, big takeaways from, how to conduct these properly. And certainly there's a lot of information online about, how to utilize these properly.
Great, thanks, Damien. I'm gonna take us home now that Sumed's talked about how we start these systematic reviews, meta-analyses. Damien's talked about the ins and outs of getting them started, getting them going. There are some aspects within these studies that require some fine tuning and can really set a paper apart. And for those interested in publishing, can actually make the difference for many reviewers, whether or not they're interested or not in what you're presenting them. A lot of what I'm talking about today actually can be found online. I've had the privilege to work with some very smart people on putting together these sort of like pearls and sort of like recommendations for what to look for exactly in neurosurgery and spine surgery, and they're available online. One's in neurosurgery, the other one's in spine. And if you need, you can email us later for a copy of these too, but the details are below. So I'm going to summarize a lot of what was said in these two papers. The first question, at least when you look at these sort of meta-analyses, you look at the statistical things used. There are two types of models, and this has started to really, look at, the quality of the stats being provided. There are two types of models: random effects and fixed effects. And, I'm going to talk quickly about them, but the pearl of this is really to rely more on random effects for conservative but more accurate sort of outcomes. And it's a different type of statistical analyses in how you pull the data together. You find the studies as Damien's highlighted, and then you take the data out as Sumed's described. And then once you have the data and you try to pull the data, there are many statistical ways of doing it. Fixed effect model assumes that all studies contribute equally to the overall pooled value, whereas a random effects actually weights it based on how big the study is, for example, which tends to make more sense when you think about it. A study with 200 people probably have a better, reliable, reproducible incidence rate of a complication versus a study of 5 people. And that's why random effects is very useful, as it's conservative but more reliable. Nonetheless, though, there are examples where fixed effects is useful, and that's more when the studies are more consistent and it just provides a stronger statistical outcome. But nonetheless, if you're getting started and if you're starting to interpret these and you're starting to write these, if you have a choice, always rely on the random effects. And then if you are going to use fixed effects, I would recommend justifying why. But nonetheless, there are different options in the software, but that's the first thing. Look at the modeling, look what they've done, and then justify to yourself which model you use to pull the numerical data. The next question, the next pearl really to share here is to look at the certainty of each reported assessment outcome. And, Damien really highlighted the grade assessment, and it's a great chance for me just to reiterate it. I've changed my practice when I write these, and I think it's very compelling when I review manuscripts to see this here. Anyone can search the literature, anyone can find an average of the data, but the beauty and the value really of these systematic reviews lies in the grade assessment, all these recommendations. And just to expand a little bit more upon what Damien said, these certainty assessments take into consideration multiple types of factors about these studies, including the evidence, the quality, the consistency, the directness, and the effect size, and then pulled together you can generate a certainty assessment, which truly is the value of these studies, in my opinion. Because it says to someone that wants to see if you can translate these into clinical practice, whether or not you're very certain about a particular intervention or a particular thing. Because if there are, for example, only 2 studies involved in a data point, you can't be that certain about it, and you then can't really have the same gravitas to impact your clinical judgment. But grade assessment is another one. The next value that might go unnoticed a lot of the time is heterogeneity, effectively, and it's very important. And I think along with the grade table, mentioning heterogeneity is one of the more important things a systematic review and meta-analysis can do. And that's by using what's called the I-squared value and the P heterogeneity value. Here's a quick paper. Here's a paper that I wrote looking at adjacent segment disease by 2 different approaches. ACDF and total disc replacement. And you can see here in this study that not only have we pulled the data, but we've also provided in the red brackets an I-squared value and a P heterogeneity value. these here are key because what this tells us is how consistent the studies are. Are the studies very consistent? If so, then the P will not be significant, like the top red box. But if they are not consistent, significantly inconsistent, the P will be significant, like the bottom red box. And you can see that's because there's an outlier of the bottom study. And knowing how consistent the literature is benefits many ways. One, it tells the reader how consistent the studies are, which is of interest to many readers, how consistent any sort of conclusion is. But on top of that, some people also use this as a value to justify doing a fixed effects model or a random effects model to justify the statistics. But nonetheless, reporting of the I-squared value is not always done by meta-analyses, and something I think should be, as well as the P heterogeneity value, because we're really not, as these guys have said before, not generating new conclusions, but rather summarizing the literature out there, which includes saying how consistent the literature is. Again, here's a similar example of looking at operation duration of this study. You can see in both cases, the P heterogeneity value was significant. And as you can see in the pooled study, they are not very consistent. And it's important to realize this because sometimes then it brings into judgment whether or not you should have pooled these studies in the first place. The next pearl to consider is bias. Again, the beauty of these systematic reviews and meta-analyses is that it allows you to review the quality of these studies. And it also allows you, once you extract the data, to look and see what, how reliable the outcomes are. This is another study I did looking at the addition of duroplasty to posterior fossa decompression for Chiari patients. And you can see here when we looked at this, we looked at multiple things, not only pooling the data, but we also used funnel plots to look for publication bias. And we also used leaves one out sensitivity analyses to look and see whether or not these trends were truly affected by any particular study. And this is an example of a forest plot. Sumed mentioned, you know, there are multiple programs out there that can be used to generate these plots, and there are, and it's just always nice. And to me, it always signals someone that, you know, is also valuing the reader's time by saying, you know, we understand that these are the studies, these are the poor conclusions, but more importantly, are we looking for potential sources of bias? Because if they are, you have to acknowledge them as a limitation for your study and your conclusions as well. This here is an example of sensitivity analysis or a leave one out analysis. And as the name suggests, what this does is it just takes one study out at a time and recalculates the overall pooled value. This here is just another technique that allows you to see if one study is really dominating the overall effect or not. There are multiple other sensitivity effects out there. There are small study bias analyses and multiple other sort of post hoc analyses. And reading them gives you comfort to know that the authors have considered this as an option, and writing them gives you the chance to show the reviewer that you are considering all options as well. So I highly recommend that too. So there are a couple concluding remarks we'd like to have before we open the floor to any questions if there are any. And the first concluding remark really is, what is the value of these studies? Are they clinically significant? Here's a study going back to that ACDF example. And what we found in this study, when we looked at overall intraoperative blood loss, was that there was a significantly lower blood loss using hybrid surgery versus ACDF. But that significant blood loss was 25 mils. And now the question here really is, what is the clinical value of saving 25 mils in a surgery? And there are definitely people that would say there isn't. You know, if 25 mils is the only difference between two techniques, are you truly going to change your choice based on 25 mils? And you can see there the pool means also highlight, you know, with an overall loss of 167 versus 202. So it's very interesting discussion to have with meta-analyses, because a lot of studies produce numbers, and if they produce numbers, by virtue of that, you can do a meta-analysis on them. You can pull them together, you can weight them, etc. But then, as you can see in this example here, with 25 mils difference in intraoperative blood loss, is that really going to change your practice in what technique you choose? And if not, when you write this, you have to really justify why you're including it in a study like this. So to be quite brief about it, when to do one in neurosurgery, you know, there's obviously, everyone sits multiple ways on this particular topic, but my personal take is that, you know, it's when there's a novel PCOS question to be asked, there's no point doing another meta-analysis that has been done a couple times before. I recently was looking up a topic and found that in the last 6 months, and 5 meta-analyses on the same question have been published by different journals. That's another question of who bears the responsibility to sort of officiate what goes in there. But truly for me, I think if it's a novel PCOS question, I think it can contribute to the literature rather than just repeating the same topic. In regards to meta-analyses, I would argue you need at least 5 studies to actually pull one. I know people have pulled them with less. I mean, technically you only need 2 studies to do a meta-analysis and pull them together. But to get anything meaningful statistically, my argument is 5 studies. And this is a very nebulous definition because some people would argue 10, and there was one study out there that calculated you needed 14. So it varies. But again, to have a very robust sort of meta-analysis, I would recommend at least 5 studies that you could find. And truly to look at, outcomes that can influence decision-making, outcomes that can influence practical, it could be a practical benefit. For example, intraoperative blood loss could be a very important outcome if there's a drastic difference. And so, that can influence decision-making, for example. And I think this is one caveat that I really like to remind myself of. Although there's lots of neurosurgical data out there, when pooled, they don't always lead to clinically actionable outcomes, which really just begs the question when to do one. And that really comes down to your own clinical judgment as well as that of your mentors as well. So, I mean, I think we'll finish off here with the question of where to now, where are we going? Because as you can see, up until recently, this has been growing at an exponential rate. There are multiple ways I think this can go. This can keep climbing. There's no doubt the literature continues to grow. Multiple new techniques are discovered, different analysis approaches are being created, and there's no reason to see why it can't continue to grow at this pace. The other option is it kind of plateaus at this point, whether or not these studies are treated the same way as cohort studies in terms of their value and remains, at the forefront of journals and their publishing remains to be seen. And the other question is perhaps maybe these will drop. We're not sure. I mean, this is also possible as well. For example, there might be new rules put in place to prevent redundancy, which is currently, prevalent in some particular niches. And so, there are multiple questions to be asked where we're going with these. But for the time being, I would argue, and I'm sure Suman and Damien would agree with me, that these studies do have a place in the literature. It's just how to, define their place correctly and use them correctly rather than for other potential benefits themselves. So with that, we'd like to open the forum if there are any questions out there regarding any particular aspect of meta-analyses or what we've talked about. You can either use the chat function, I believe, is one thing here. And we're more than happy to share what we think, the value of these studies are and where they might continue to go. So yes, if there are any questions, please go ahead and type this in. We have one question already, and it's what statistical package or program do you prefer? And also what time frame is appropriate to update a systematic review? I can have a go at this one. Well, I guess we could all say what programs we use. I personally started off with RevMan and then progressed to Stata, and now I am trying to learn R actually, but for all intents and purposes, they all do well. It's just where you want to take your skills to. And in terms of the time frame, when to update one, there's a lot of talk about a lot of these studies being published. I personally think, at least, if there's new data. I mean, there's no point updating one a year later if no new studies have been produced. And so if there is new data, within a reasonable amount of new data, I would recommend that. For me, in my experience, I found that to be anywhere between 6 months to a year or two, but definitely not within 6 months. And this is all to do with the search date rather than the publication date, because some studies can run their searches and then publish maybe a year or two later. So those are things to consider. The next question is, how do you calculate the I-squared value? That's a great question. Do you do it by hand? Do you use a specific program? That comes out with all the programs they produce the I-squared value for you. You don't have to calculate that by hand. And then maybe Damien, you might want to answer the next question is how do you do the grade assessment? Is there software or is there a checklist?
Yeah, and not any software as far as I know, but the grade assessment you can look on the website, and It's really kind of your own clinical reasoning. And, ultimately there's the guidelines, the levels of evidence, and they have from very low to high. And so that's kind of why it's subjective, and that may be one of the downsides, although it's the most widely accepted assessment that we use now. And so honestly, like, really, especially when I was first starting out, it's something to simply Google and say grade assessments, look at papers. Because I don't believe there's an actual checklist. It's more using your own kind of clinical judgment as you analyze the paper and look, okay, was it a randomized clinical trial? Okay, well then that's, more than likely a higher level of certainty. But if you have one randomized clinical trial and 15 other observational studies, then your evidence pool is probably not going to be the highest it could be. So there's a little bit of subjectivity that comes into there, and that is kind of maybe the biggest downside to that particular assessment. I can also answer the next one about starting meta-analyses. Do we have to register them on Cochrane? I don't believe so. You guys can correct me if I'm wrong, but this does bring up a good point about the Cochrane Library, which is another incredible resource for systematic reviews, and they've got systematic reviews for a number of different topics. I don't know how many neurosurgical focused ones there are, but it's a very well-known library of very rigorously done systematic reviews with hundreds of papers sometimes. And so that can be, you can go on their website, and that's another resource to look for and say, oh, is this a topic that has been studied before?
And Damien, I would just add on top to this, this person who's asking the question, that there are multiple registry sites actually where you can register your intent to perform a systematic review meta-analysis and highlight them. I think there's one in the UK actually that's quite prominent. And if you look through the PRISMA guidelines, that is one question: is this study being registered on a registry? I would say that, that is the PRISMA guidelines. There's definitely something you can do, but just be cognizant of the time. To register these things online, it's not just a click and you're done kind of thing. It takes time because each application needs to be reviewed. So it's just something to consider in your timeline as you go about setting something up.
The next question is, we see here, how does the neurosurgery community accept articles which were written by non-surgeons? Is it valid to do one? I can take this one. I think it is very valid to do something like this. Now, I will say that it would be beneficial to have, try to find a way to include a neurosurgeon within this meta-analysis. But for the most part, the actual doing of said meta-analysis does not require you to necessarily have surgical skills. It doesn't necessarily need you, to necessarily understand the exact nuances of the surgical techniques and such, but it does require you, I think, to understand what problems face neurosurgeons. And so if you have kind of an idea of that, and I think one of the best ways to do that is to involve neurosurgery specifically within your publications. It doesn't need to be run or head by a neurosurgeon, but definitely including or collaborating with the neurosurgical team at your institution, at another institution. Just having someone on the paper that's a neurosurgeon is very beneficial. It adds a little bit of credence to the actual conclusions you're coming up with. And there's a neurosurgeon kind of telling you that this is really not relevant clinically, then that's a question you have to ask yourself: is this meta-analysis clinically relevant? So then the next question, do systematic reviews, meta-analyses need to be invited by journals, or will journals consider any topic you submit? It depends. In my experience, I have been able to submit systematic reviews, meta-analyses to journals and have them review like any other paper. That being said, there are some papers and some journals that have specific invited special editions. And so reaching out to the journal before you submit your paper is beneficial to you. I don't know, Victor, Damien, what your experience have been with this.
In my experience, for the most part, you generate the idea with you and your mentor or your team, and you can submit anywhere. There are some journals out there that require these studies to be invited by the editor. They're few, but they do exist. But for the most part, in my experience, there's no limitation. You don't require an invitation to submit.
For incoming medical students, how would you recommend starting out and educating yourself on topics you're interested in / finding mentors in areas of interest? Well, I think I can just really quickly start the answer for this one. Finding a mentor is as easy as truly finding out like what you're interested within the context of the field that you are interested in. Neurosurgery, for example, I was interested in brain tumor, and that reaching out to some of them, very straightforward, very easy to do. A lot of them will have topics of interest to them that you can kind of piggyback off of. So I think the first real communication to do these kinds of studies really starts from you as a student, you as a young doctor, kind of going out there and saying, I am interested in doing research with you, with XYZ person. Do you have ideas? Is there something I can get started with? That's kind of how I got my start. And then educating yourself on how to do, I mean, you're doing that now. You're learning kind of just the basic verbiage, the terminologies that are being used, and this is going to allow you to just literally go online and type in I squared. If you don't remember what Victor said, what heterogeneity really means. Damien, Victor, want to add anything to that?
Yeah, I mean, I think, very similarly, you come into medical school and you're looking to get involved, early on. And if you want to do neurosurgery early on, then, that's fantastic. And so you want to try and immerse yourself as quickly as possible. Go into your department if your medical school has a home neurosurgery program. See if you can find some of the fourth year, third year medical students that are interested in neurosurgery, whether it's a interest group you have, and use them to get connected and plugged into some of the residents and faculty that have ongoing projects that they know like to work with medical students. Not every faculty member, not every resident has the time, or the energy to work with medical students, but a lot of them, generally do, especially if they're at academic centers. And so they're more than happy to get you involved. And so at that point, then it's just opening yourself up and trying to kind of hone in on whatever areas of interest you are. And then once you find that mentor that, you're invested in and they're invested in you, it can be a really, really fruitful relationship for you.
The only thing I would add, because I echo all the sentiments said just then, is that if it's specific to a systematic review and meta-analysis that you're interested in being involved in and finding a mentor, a really good way to do that is to search mentors up and see if they've published these things. If they've published these things, they might be more aware of it than someone that hasn't. And there are many ways you can look, mentors up. You can look them up on PubMed, you can look them up on Google, you can look at their profiles. But finding someone that has done a meta-analysis, every meta-analysis comes with a corresponding author. You can always email that corresponding author, and more likely than not, that those people will be open to questions and perhaps even collaborations in the right time. So specific to those, that is also a good way to consider as well. And so obviously, guys, we thank everyone that's listened. Please, if you have any more questions, put them there. But just quickly, this resident hour, we are very interested in continuing as a resident group here at Miami. It won't just be us, it's going to be multiple residents across all different levels and years. And so the next thing we're going to talk about is a little shift in topic, but it's going to look at, something that is very pertinent to today, and it's looking at how within neurosurgery, diversity and inclusion can lead to proper practice. And we'll have other residents talk about their experiences and give you a better insight into how we at UMiami do things, which is very exciting to share with everyone. Please sign up if you haven't already at the login below. And finally, for all of those people we did get asked a question, these are our contact details. Feel free to reach out to any of us, all of us at the same time if you have any more questions. It's been, I can speak on behalf of all of us, it's been a pleasure to be able to share these views, share a bit of the University of Miami with you, and we hope you've enjoyed it. And please, if you have any feedback, reach out to us as well. We'd appreciate that too, guys.
Thank you all for tuning in. Look forward to seeing you again.
It was a pleasure. Thank you so much.